often we see stormy events and babies may bleed at any point in time, and giving RBCs and platelets is sometimes a dire emergency and sometimes it could be elective. So what we are going to really discuss in the next 40 minutes would be, what are the common issues? When do we give blood? When do we give platelets? What is the rationality? And we all often realize that less is more as far as transfusion practices are concerned. And what I am going to discuss with all of you is to look at the recent guidelines, evidence, and at the end of our session, probably we would be more logical and rational when it comes to giving PRBCs and platelets and when not to give. So coming to packed RBCs, what are the factors which would really determine when to give blood? And if you look at the most appropriate indication or factor which determines transfusion is the hemoglobin or the hematocrit level. And we have been taught since MBBS and MD days that whenever a baby is anemic, and by that we would say that the hemoglobin or the hematocrit is low, that would be an indication to give RBC transfusion. We all know the role of blood, which helps in transport of oxygen from the lungs into the systemic circulation. And at the level of the tissues, it maintains the metabolism in aerobic pathway. If there is low oxygen, obviously the cell would go into anaerobic metabolism, and thereby there is wastage of ATP, there is increased buildup of lactates, and there is more oxygen extraction, as a result of which there is mixed venous oxygen saturations would fall. And often lactates, mixed venous saturations are not very specific and they cannot be used as indices for giving blood. Near infrared spectroscopy, where it measures tissue level oxygen, is again very experimental or at research level. So when it comes to the factor which determines transfusion, we are still at hemoglobin or the hematocrit, which is the most important objective way of determining the need for transfusion. When you looked at transfusion in newborns, basically it would be anemia that is an indication to give RBC transfusion. But at the tissue level, it would be hypoxia. And often if the hemoglobin is low, it would affect function of vital organs such as heart, brain, and as a result, it could impair the neurodevelopmental outcomes. But more important, it is the delivery of oxygen which helps the tissues to grow and the babies to achieve optimal growth. So we have to strike a balance between too little and too much. So when it comes to transfusion, what are the beneficial effects of our packed cell transfusion to a newborn? It is beneficial in a sick preterm baby, wherein circulatory hemoglobin is optimized. It improves the tissue oxygenation and thereby maintains the cell in aerobic metabolism to achieve good supply of ATP molecules. If the hemoglobin is optimal, obviously the heart has to function less. If the hemoglobin falls, the heart has to pump faster and it has to increase the strength of contractility to maintain cardiac output. So achieving optimal hemoglobin helps reduce the cardiac output to maintain the same level of oxygenation. So this all sounds physiologically really well. So if your hemoglobin is good, your cardiac output is optimal, the heart is functioning well, the babies would do well. However, studies have really not proven this, that giving blood really helps these babies. So let us see what and when as far as transfusion is concerned. Is transfusion a benign process? The obvious answer is no. There are inherent risks of giving blood and blood products to a newborn baby. Now, if you look at a newborn baby, there is antenatal transfer of maternal antibodies to a newborn which is immunologically immature. So obviously, there would be a question of compatibility. The organs are immature. And the newborn babies, especially preterms, are susceptible for infectious and immunological complications related to transfusion practices. Plus, the blood volume is less and the myocardial contractility is less. As a result of giving more volume, these babies are more vulnerable for hemodynamic instability and at times they can land up into congestive cardiac failure. So one has to be really careful as to giving extra volume in these babies. So the logical way obviously would be the indications for giving blood in these babies is symptomatic anemia, wherein a baby may be desaturating, there is tachycardia, there is bradycardia, there is increasing oxygen requirement. And these are often very non-specific factors because they can occur in so many other diseases such as sepsis, asphyxia, hypovolemia. So symptoms of anemia are not very specific when it comes to looking at the vital parameters apart from clinically observant pallor. So people have looked at certain thresholds wherein you could look at a hemoglobin or hematocrit level and then decide about giving transfusion. Whenever there is an acute blood loss, like a baby who has got massive pulmonary bleed or GI bleed or a hemorrhagic disease of newborn or a cord ligature which has slipped and the baby has lost blood, obviously that would be an apt indication for giving packed RBCs. However, one needs to really look at benefits versus the risk, because giving blood and blood products, you have to really judge whether are we doing right or there are obvious risks associated with the need for transfusion. So this is where we are going to discuss what is the current best possible way forward in terms of giving RBC transfusion. So obviously, if you look at this question, when to give packed cell transfusion, I thought of three possible ways by which one would decide. The first and obvious indication is a clinician's perspective. Well, you and me go for rounds in the neonatal ICU and we see a baby who is pale, and we obviously tell our resident, this baby is very pale, let us give blood. And that's probably the least as far as evidence-based medicine is concerned, because that pallor could be because of hypothermia, that pallor could be because of autonomic instability, that pallor could be because of shock. So all babies who are pale doesn't mean that we need to give packed cell transfusion unless you have a documented low hemoglobin level. So that stands very low as far as test of evidence is concerned. The second possible way would be evidence-based strategy, and we would go through some studies which would enlighten us as to what would be the rational way of giving packed cell transfusions. And the third possible way by which I thought we could discuss about packed cell transfusion is guidelines. And guidelines are made by you and me, where we look at various ways in which studies have been done, observational, cohort, or randomized control trial, and we formulate a guideline and then abide by the guidelines to give blood transfusion or platelet transfusion. So the decision for RBC transfusion is often made by the clinician based on clinical judgment, but most important to look at the national or the local guidelines which are available in day-to-day practice. And I'm sure NNF has recently come up with our own guidelines in the form of evidence-based medicine, where people now have strict guidelines, and we all can follow those guidelines to make it more rational and more logical. And Akash is one of the authors for these evidence-based strategies as far as NNF is concerned. So I looked at some of the guidelines, and these guidelines basically are based on what is the gestational age of a baby, whether it's term or a preterm baby, what is the postnatal age, whether it's in the first 24-48 hours versus first 7 days and after 7 days, whether the baby is on ventilator or baby is on CPAP or non-invasive ventilation, and what is the oxygen requirements, and whether the baby has requirements for ECMO or has any underlying congenital heart disease. So there may be various factors which would help us make a decision about transfusion in a newborn baby. Now, these are some of the guidelines from various countries, and where they have looked at postnatal age, oxygen dependency, and the cutoff hemoglobin. I would not take you through a lot of details, but if you look at the Canadian Pediatric Society and the British Committee for the Standards in Hematology, which is applicable for preterm babies less than 32 weeks, the cutoff is higher in the first week of life. It's 35% hematocrit if a baby is receiving oxygen or on respiratory support, and it is much less in babies without oxygen. British, again, it's 12 grams in the first week of life and 10 after 2 weeks. But a baby who is not on oxygen and growing well, one could wait till 7.5 grams% after first 2 weeks of life. The French are even more conservative. In the first 7 days, it's 11 grams, and more than 7 days, it's 10 grams versus 7 grams in a baby who is more than 7 days. So what we could understand that here, the bottom line here is that if the baby is on oxygen or on respiratory support, we would maintain a hematocrit of somewhere between 30 to 35, versus if a baby is not on any support, one could wait up to 23 or even 21. So that's where we are in terms of certain guidelines which are available. If you look at the Australian Society, in the first week, one would have something between 11 and 13 versus 10 to 12 if the baby is not on oxygen. And in third week, one could wait about 8.5 to 11 versus if a baby is receiving oxygen, versus 7 to 10 if the baby is not on oxygen. Again, it tells us that the babies who need oxygen, need CPAP, need NIV, need mechanical ventilation, the hematocrit should be above 30 or somewhere between 30 to 35. And if the baby is not on any oxygen, one could wait about till about 23 or 25. So that's where we are in terms of the guidelines which have been formulated by various countries, and our own CPG guidelines roughly believe the same figures. Now, I thought we would look at some of the randomized control trials which have been designed for packed cell transfusions in newborn babies. Now, the first trial that was published was the Iowa trial, which was published by Bell. This was a trial which was conducted in less than 1,000 grams, and the gestational age was 22 weeks to 28 plus 6. And the age of enrollment was 48 hours of life, first 48 hours. Now, this was a study where they looked at liberal versus restrictive guidelines, that is having a cutoff which was slightly more versus a little bit conservative. The birth weight varied from 500 to 1300 grams, and they had 3 phases. The phase 1 was babies who are on mechanical ventilation. Where the cutoff was less than 46%, you would give blood in one group, and less than 34% you would have the restricted group. In phase 2, it was CPAP or oxygen. Again, the cutoff was 38 and 28. And in phase 3, these were babies who neither had CPAP nor oxygen, and they waited for 22% versus 30%. The objective of this study was to determine if restrictive guidelines for packed cell transfusion in preterms could reduce the number of transfusions without having any adverse consequences in the preterm baby. And let us look at the outcomes. Now, if you look at the liberal versus restricted, there were 51 and 49 babies, and the survival, PDA, IVH, periventricular leukomalacia, the IVH were not significant. The only thing which was significant probably in the restricted group was there were more babies with some brain injury, which was grade 4 IVH or periventricular leukomalacia, and this was 6 versus 0 babies. Otherwise, all the other parameters like BPD, ROP, oxygen dependency, time on ventilation, everything else was absolutely no different. So what did they conclude? There was no difference in the outcome as far as mortality was concerned, and there was no difference in the short-term outcome. Restricted transfusion babies had more brain injury in the form of grade 4 IVH or PVL. Now, this was statistically significant as far as IVH was concerned. Severe adverse brain events in the form of intraparenchymal brain hemorrhage, PVL, or both were slightly higher in restricted group, 6 versus 0, and this was significant. So they thought that this restricted blood policy probably had more injuries to the brain, and that was their observation. Now we'll go to the details of these in a couple of slides later. The second trial that was published, again, a big trial which was done for the premature infants in the need of transfusion trial. This was the PIN trial. Now this was again babies with gestational age less than 31 weeks, birth weight less than 1,000 grams, and the age of enrollment was again 48 hours. There were 2 groups, liberal versus restricted level of hemoglobin for transfusion. And the primary outcome was a composite of mortality before discharge or survival with severe morbidities like ROP, BPD, and brain injury on cranial ultrasound. So this was a composite outcome that they studied, and this was done by Harish Kriplani and group from Canada. So this was the largest randomized control trial. Now they enrolled 451 babies, and they looked at low threshold and high threshold. And if you look at the outcomes in the form of mortality, and there was no difference. So the p-value was 0.25, and the treatment effect was no different between low versus high threshold. So in PIN trial, the babies who, one or more transfusion in the low threshold was 89% low versus 95% in the high group. The primary outcomes were 74% in the low threshold versus 69.7% in the high threshold. So there was no statistical difference in the mortality or adverse outcomes as far as short-term outcomes are concerned. So here, this was a larger trial as compared to the Iowa trial, and they did not find any difference in the mortality or morbidities as far as short-term outcomes are concerned. Now, if you compare Iowa versus PEN trial, Iowa group had the hemoglobin was slightly higher. The threshold that they kept was 15.3 versus 13.5 in the PIN trial. So PIN trial, the difference basically was in the hematocrit level. The higher threshold was 13.5, where the low threshold was comparable in both the groups. And in the Iowa trial, non-respiratory babies had 10 grams versus 8.5. And in babies where there was no oxygen requirement, it was 7.3 versus 7.5. The lower hemoglobin threshold was similar, 11.3 and 11.5. The only difference that one would see was in the higher hematocrit level in the Iowa trial. So early outcomes and the hemoglobin threshold, what did we find? There was no clear difference between the low and the high hemoglobin threshold as far as outcomes were concerned. Obviously, if you keep a lower hemoglobin as a threshold, the babies would need lower transfusions or fewer transfusions. And that was what they really found, that in both the studies where the low hematocrit was cut off, these babies received less transfusions. Fewer transfusions with lower thresholds in both the trials were observed, but there were slightly more apneas and there was slightly possibly more brain injuries in the lower threshold in the Iowa trial. So this was a basic difference, but this difference was, the study was never powered for brain injury. This was a secondary post hoc analysis that the Iowa trial found. As far as PIN trial was concerned, they did study the long-term outcomes, and they found some cognitive delay in the post hoc analysis. So there were some issues that if you keep a hemoglobin which was less, and if you found that the Iowa trial found that there were more adverse brain injuries in the secondary outcome, which the study was really not powered, does it mean that restricted hemoglobin is associated with adverse brain development? Does it mean that keeping the hemoglobin low in the first few days of life is going to affect the neurological outcome of these babies and neurodevelopmental outcomes of these babies? That was something which raised a lot of questions. So then came these two big trials which looked at outcomes with low versus higher hematocrit level. The first study was transfusion of premature babies. This was the transfusion of premature trial. This was the top trial. They looked at restricted hematocrit, that was 21 to 32% versus liberal, that was 32 to 38% as a practice for RBC transfusion. 1,824 premature babies with gestational age less than 29 weeks and birth weight less than 1,000 grams were enrolled. The primary outcome was neurodevelopmental impairment or death before assessment, and there was no difference between the two groups. 50.1% in high threshold versus 49.8% in low threshold. The neurodevelopmental impairment in these premature babies was 39.6% in restricted versus 40.3% in liberal group. So what was the conclusion of the top trial? There was no difference between restricted and liberal transfusion policy as far as the outcomes were concerned. And if you look at this results, what did they found? They obviously found that there was no difference in the death or the neurodevelopmental impairment between the two groups, that is higher threshold versus lower threshold. And this was a big trial, and the results showed that keeping lower hematocrit was not associated with adverse neurodevelopmental outcome or higher mortality. And this does conclude that you could probably be wiser if you give less transfusions. Now, there was another study which was published in a matter of 7 days. And this was again 2020, published in JAMA. This was the ETT-NO study, which was effect of transfusion thresholds on neurocognitive outcome in ELBW babies. 1013 preterm babies less than 1000 grams. They had two groups again, liberal versus restricted, where the liberal was 28 to 41% hematocrit and restricted was 21 to 34%. RBC transfusion thresholds were followed, and the outcome that they studied was risk of death or disability, wherein they looked at cognitive deficit, cerebral palsy, or severe visual and hearing impairment at 24 months corrected age. And what did they find? They found that there was no difference between the two groups, where the primary outcome they found was 44.4 versus 42.9% of odds ratio. And this was statistically not significant. So this was the ETT-NO randomized control trial, and they found that death or neurodevelopmental outcome at 2 years was no different. There was no difference in the cognitive outcome. There was no difference in the Bailey score at the mental scores or the motor scores. There was no difference in cerebral palsy. There was no visual and hearing difference in the two groups. So what really we have learned from these two big trials was that if I keep restricted versus liberal, there was no difference in the long-term outcomes at 2 years. Then came the systematic review, where they looked at restricted versus liberal transfusion and in VLBW babies. So they assessed the two groups. There were 6 RCTs where they looked at 3,483 participants. Restricted transfusion did not increase the all-cause mortality compared to the liberal group. There was no difference in the composite outcome of death or neurodevelopmental impairment. So basically, if you look at the current evidence of RCTs and the systematic review, restricted transfusion for RBC transfusion, restricted threshold for RBC transfusion was not associated with increase in mortality. There was no difference in the short-term adverse outcomes, and there was no difference in the long-term neurodevelopmental outcomes, cognitive outcomes, hearing or visual impairments. So that's where we are in terms of the evidence in favor of restricted compared to liberal transfusion. So what have we learned? Well, if we look at the guidelines and the evidence, there is no evidence for advantage of maintaining the ELBW babies with higher hemoglobin level in the first week of life. There is no neurological benefit in the higher hematocrit levels. In fact, if you follow restricted transfusion, there is reduction in the number of transfusions. And this was 2.9 versus 1.7 in the ETT-NO trial versus 6.2 versus 4.4 in the top trial. So it does help us understand that if we follow restricted hemoglobin levels, then fewer babies are going to get transfusion. And I think the message that we would like to remember is avoid transfusions as much as possible in these preterm VLBW or ELBW babies. So basically, hemoglobin threshold should not be above 13, or it should not be below 11 in the first week of life in a critically ill baby, and hemoglobin not above 10 or below 7 for stable babies, and older babies who are critically not so sick or who do not require any respiratory support. One could wait till about 7 grams. Using lower threshold, that is 11 grams for critically ill and 7 grams for stable babies, help reduce significant number of transfusions. And that is what we have learned from the top trial and the ETT-NO trial. Now coming to platelets, when do we transfuse? Now platelets are a very unique cells. Basically, they have to be group identical or they have to be compatible with ABO phenotype. When it comes to a neonatal non-immune alloimmune thrombocytopenia, they have to be human platelet antigen compatible with the mother. Leukodepleted and CMV negative platelets are safe, and irradiated platelets if indicated. Now, if you look at the trial of platelet transfusion thresholds in premature infants, there was a big trial which was the Planet 2 trial. Now, this trial looked at 2 thresholds. In one group, they wanted to maintain a platelet count of 50,000 and above. In the other group, they wanted to maintain a platelet count of 25,000 and above. So anytime a platelet would fall in less than 50,000, one would give platelet in a higher threshold. If the platelet fell below 25,000, then you would give platelets that was a lower threshold. The age of enrollment basically was less than 34 weeks of gestational age. There were 660 babies which were enrolled. What did they find? In the higher threshold, 90% of babies received platelet compared to 53% in the lower threshold. And they did find that those babies who received more platelets or higher threshold, there were higher BPD rates. It was 63% versus 54%, and this was statistically significant. New major bleeding episodes or death occurred in 26% of babies in the high threshold versus 19% in low threshold. So this was something which was very contradictory to what they expected, because if I maintain a platelet above 50,000, why should there be more bleeding episodes and more mortality? And this was something which was against what they expected. Now, this was again a study where they looked at the outcomes, and they did find that the odds of dying or having major bleeding in the first 28 days was much higher in the higher threshold. It was 85 out of 324 compared to 61 out of 329. So it was 26% versus 19%. And the odds ratio was 1.57, which was statistically significant with a 95% confidence interval. So this was something which tells us that less is more as far as platelets are concerned. If you look at the other outcomes, again, it tells us that there was higher incidence of BPD, there was higher incidence of bleeding, and there were probably higher incidence of NEC. So this was significant, and NEC was not significant even after randomization. Coming to some other evidence as far as platelet transfusion was concerned, there was an old trial by Andrew et al., and they looked at prophylactic platelets with less than 150,000 versus 50,000. And there was, again, they looked at extension of IVH. They did find that there was no difference in the outcome if you maintain less than 50,000. So I think less is more. Then there was another study by Curley et al. Where they looked at less than 34 weeks of gestation, where they wanted to give prophylactic platelet at less than 25,000 versus less than 50,000. And the primary outcome was death or major bleeding. And they did find that it was 1% versus 19% in the low versus higher threshold group. And the third trial was by Kumar et al., where they looked at less than 35 weeks of gestational age with PDA in the first 14 days of life receiving NSAIDs. And they wanted to give prophylactic platelet at less than 1 lakh versus less than 20,000. However, the primary outcome was time to PDA closure. And they found that the median time of PDA closure was 72 hours in both the groups. And liberal group had IVH in 40.9 versus 9.1% in the restricted group. So that is where the platelets and RCTs and evidence comes from. So if you look at indications for transfusion of platelet and platelet concentrates, I think today probably one would give prophylactic platelet only if the platelet count is less than 25,000. If the platelet count is between 30 to 50,000, consider if the baby is less than 1 kilo, if the baby has IVH, if the baby has concomitant coagulopathy, a critically ill newborn with sepsis or fluctuating systemic blood pressure, and if you are doing invasive procedures. However, if the platelet count is more than 50,000, consider giving only if the baby is bleeding. Otherwise, there is no role of giving prophylactic platelet if the platelet count is above 50,000. So less than 25,000, yes. Between 25 to 50,000, only if you have one of these features, one would consider giving platelets prophylactically. So that seems a reasonable approach, that if your baby has got platelet count less than 25,000 and not bleeding, in the first week of life, consider giving platelets. In all other babies, look at the clinical picture, look at the severity of the bleeding, risk of bleeding, and don't just treat the platelet number, and take a clinical perspective in picture before giving platelets. Now, next half of my talk would be on transfusion related issues. Often we are asked, what should be the group of the blood that we are giving? And obviously we have been taught that one should always cross match the blood with the baby and the mother. So if the baby's blood group is O, you would give O. As far as RBCs are concerned, and platelets can be O, or It could be AB or A or B in case of emergencies. If the baby's blood group is A, you could give A or O. If it is B, you could give B and O. And if it is AB, you could give AB. So this is as far as RBCs and platelets are concerned. Plasma, obviously, it is something different, and we would not cover that in today's talk. Now, how much blood to transfuse? Often, transfusion criteria for BLBW baby are based more on consensus and experts rather than evidence. But by and large, volume of RBC is equal to desired hematocrit minus observed upon packed RBC hematocrit multiplied by neonates blood volume. Now, this is a very good formula to give in exams, but most of us probably give up about 15 to 20 ml per kilo of transfusion every time that we want to give blood. So RBC transfusions are given in 10 to 15 or sometimes maximum 20 ml per kilo and the transfusion should be completed within over a period of 4 hours. Normally, hemoglobin level would increase by 2 to 3 grams. However, it also depends on the hematocrit of the blood that you are giving. And the hematocrit which is desired should be between 60 to 70% of the packed RBCs that you are giving. Should we irradiate? And the answer is yes. Blood components must be irradiated, and the irradiation is to the dose of 2,500 to 5,000 rads. Once irradiated, the RBCs must be transfused within 24 hours. Irradiation does not change the expiry date of platelet concentrates. Now, why do we irradiate? Why do you want to irradiate? Obviously, it reduces the incidence of graft versus host reactions. Irradiation does cause leakage of the potassium from stored RBCs, and it may reduce the shelf life of irradiated RBCs. The shelf life of irradiated RBC is 28 days as compared to normal 42 days of a non-irradiated blood. But most important, it does reduce the graft versus host reaction, and irradiation does not prevent CMV infection. That's something which we should remember. So if you are giving blood transfusions, you are giving platelet transfusions, what are the complications, especially of the packed PRBCs? There will be metabolic complications in the form of hypoglycemia, hyperkalemia, and hypocalcemia. Sometimes immunological complications like simple transfusion reactions or febrile reactions, allergic reactions. You may have non-hemolytic febrile reactions. You may have immune-mediated platelet destructions. You may have TRAGI and TRALI, which are new terminologies. Basically, these are transfusion-related acute lung injury, where these are transfusion-related lung injuries. There could be activation of T antigen, and this T antigen activation can result in NEC-like picture. You may have transfusion-associated graft versus host reaction. Sometimes babies suddenly deteriorate, especially after transfusion. They behave like sepsis. It could be bacteremia, though rare, but once in a while you may have cytomegalovirus, which is transmitted from blood, and these babies may develop a full-blown CMV infections. Transfusion-related adverse outcomes, there is increased risk of BPD, ROP, and necrotizing enterocolitis. So these are some of the complications that are associated with transfusions in newborns. So how do we reduce the risk of transfusion-associated CMV infections? Basically, should we do leukocyte reduction? Answer is yes. One could use leukocyte filters, which can remove about 99.9% of WBCs. The rate of acute febrile non-hemolytic reactions, aluminization, allergic reactions, and transmission of certain infections can be less. If you use a leukocyte filter, there is a decreased incidence of BPD, ROP, and NEC, especially if you are giving blood transfusions. Leukodepleted blood components may help in reducing febrile reactions, aluminization, but it definitely does reduce the risk of transmission of CMV. What type of blood should we use? So we should basically use irradiated blood and CMV negative donors. One could use 2,500 rads gamma irradiation, which damages the T cells and thereby prevents them from replicating in an immunologically handicapped host, and thereby preventing transfusion associated graft versus host disease. So basically, uh, from today, I mean, we all are using irradiated blood. We all need to screen the donors for CMV infections and take it that once in a while, if a baby develops CMV infection, it can be detrimental as far as long-term outcomes are concerned, and babies may go on to develop full-blown CMV infections. Small volume versus transfusion. So basically, how can we, how much blood do we give? And often we use about 15 ml per kilo. And if we take a big bag, we are going to discard or waste so much of a volume. So instead of wasting that, one could take small volume of blood from a satellite pack or a small bag and preserve the remaining blood in the blood bank. And these are basically the small satellite packs or pedi bags, which can be used to give blood transfusion in NICUs. So blood from large unit can be transferred to several small bags in a sterile manner in a blood bank. And this in turn is going to reduce the number of donor exposures. It is going to reduce the number of donors. Therefore, the risk of infection, the risk of exposure to various donors might be less, and which will have better outcomes as far as babies are concerned. It may also help in reducing the cost of transfusions. Should the donors be limited? Our answer is yes. Multiple small volume transfusions can be fractionated into smaller aliquots, and it can be used in a single newborn. So use of these pedipacks has really helped reduce the number of donors as far as newborns are concerned. So what is the optimal type of blood to be used? So basically, we know that shelf life of a blood is about 42 days. And this was a trial where they looked at age of RBCs in premature infant. This was the ARI-PI trial, where they looked at 377 premature babies weighing less than 1250 grams. And there was no difference in mortality or composite outcomes that included neonatal morbidities in the form of NEC, BPD, IVH, ROP. When you gave babies with less than 7 days versus more than 7 days. So there was no difference between fresh and the older RBCs with regards to mortality or morbidity such as BPD, IVH, ROP, and NEC. So what we understand today is that not necessarily all babies need fresh RBCs. So fresh, that is less than 7 days, versus old, that is more than 7 days. Use of fresh RBCs is not recommended in all newborn babies. The only exception would be an exchange transfusion where you would like to give fresh RBCs. Neonatal unit should follow the standard existing practice of issuing blood bank for oldest first approach. That is, the older blood should be given first, and then the fresh RBCs, followed by the fresh donors. So this is a strong recommendation and high quality evidence that you could use old RBCs or older RBCs for transfusions. The next issue, should we give diuretics while transfusing newborn babies? We have a common habit. Whenever you give blood, we often tell our residents, give a dose of furosemide so that the child doesn't land in cardiac failure. Well, there was no effect in ventilator or hemodynamic variability. There was no difference in the adverse outcomes like electrolyte imbalances. And obviously, if you give diuretic, there's a risk of hyponatremia, hypokalemia, nephrocalcinosis, ototoxicity. So one has to really take a look at the baby, whether the baby is at risk of hypervolemia and failure and CCF, then you would obviously give a diuretic. But diuretics are not routine standard of care as far as transfusions are concerned. So please use it judiciously. Use it in babies who are at risk of failure. Washed RBCs versus unwashed RBCs for transfusion in preterms. There was only single study, no significant difference in mortality. There's currently insufficient evidence to support or refute use of washed RBCs to prevent development of significant neonatal morbidities or mortalities. This is what the Cochrane tells us. So one could use normal RBCs. Shall I feed or shall I keep the baby nil by mouth when I'm giving blood transfusion? Well, enteral feeding was withheld in at times because we were thinking that many babies are developing abdominal distension, feeding intolerance. There's increased risk of NEC when you are giving blood transfusion, and this was becoming a habit. So feeds, maybe one could withhold for about 3 hours, and that was something which is a very weak evidence. Most of us probably feel that blood transfusion and nil by mouth probably should not be followed. So stopping enteral feeds, what does the Cochrane tell us? There's only one RCT and there were no cases of NEC reported. Evidence is insufficient. So probably what we understand as far as NEC is concerned, maybe if you have a baby with anemia, it is anoxia, hypoxia, which causes gut injury, and the baby might develop NEC versus you giving a blood and there's generation of free radicals and there's increased risk of NEC or cytokines. So really the answer is not known, but currently there is very little evidence to support that you would stop feeding while giving blood transfusions. What is the effect of transfusion on ROP? When this was a systematic review which looked at 18 studies and over 15,000 preterm babies, and giving blood was associated with increased risk of ROP. The odds were 1.5 times than those babies who did not receive transfusion, and the 95% confidence interval was significant. RBC transfusion was more closely related to ROP in babies who are less than 32 weeks of gestation. Now, what we understand here is whenever we are transfusing blood, we are giving adult RBCs, and adult RBCs, as we know, have got increased delivery of oxygen to the peripheral tissues compared to a fetal hemoglobin. So the delivery of oxygen is more. This might in turn result in increased incidence of ROP. Plus, there is increase in the iron that we are giving, that a baby is getting after RBC transfusion, which generates free radicals and which may have an effect on ROP. So one has to be careful as far as ROP and blood transfusion is concerned. But more important, if you have a baby with pre-threshold ROP and there is low hemoglobin towards the 3rd week or 4th week of life, then in that case, probably your blood transfusion may help in arresting that baby from going from pre-threshold to threshold ROP. So first few weeks, you have to be very, very conservative in terms of transfusion. 3rd and 4th week, if a baby is anemic and is on the verge of stage 2 or stage 3, where the baby may or may not need laser, in that case, keeping a slightly higher hemoglobin may have a beneficial effect in regressing ROP. So it is to look at the age of the baby as far as postnatal age is concerned. In the first 2 weeks, you have to be conservative. In the 3rd or 4th week, if you have a pre-threshold ROP, maybe a little bit of blood transfusion will increase the oxygen delivery and arrest the baby into going into threshold ROP, wherein you can decrease the chances of progression of ROP from pre-threshold to threshold disease. How can we prevent or reduce transfusion? I think that this to me is very important. We all realize that delaying cord clamping for about 60 seconds to maybe longer, up to 180 seconds, is something which is beneficial. It has helped reduce neonatal mortality. It has helped reduce neonatal shock. But more important, there is more iron stores in these babies and definitely less transfusions that these babies would require in the first few months. Limit iatrogenic blood losses. So use micro methods and quantify the blood that you are letting as far as babies in the NICU are concerned. So calculate every ml of blood that you are taking out of the baby. Use more non-invasive ways of monitoring the babies, like oxygen saturation in place of a blood gas, bilirubin levels. One could use a transcutaneous bilirubinometry. As far as erythropoietin is concerned, there is not much evidence. Early iron supplementation in low birth weight babies was associated with less transfusion as compared to late iron supplementation. So one could start early once the baby is on full enteral feeds, especially in babies who are less than 1500 grams. One could start iron at about 2 to 3 weeks. Now, this was a PNUT trial, which was preterm erythropoietin neuroprotection trial, where they enrolled 741 ELBW babies, where they gave high dose versus placebo, and there was no significant difference in incidence of death or neurodevelopmental handicaps. There was significantly decreased volume of RBCs after 10 days of life. Now, this was a trial which where the neuroprotection was not achieved by erythropoietin. What also has been studied with the erythropoietin and for preventing transfusion was that they did reduce the volume of transfusion, but not the number of donors. So again, this is something which we have to understand, that erythropoietin probably may not be beneficial in reducing the donor exposure. So at the end of this session, I think what are the key points that one would remember? As far as transfusion practices are concerned, we understand that less is more. So maybe one should use restricted transfusion, restricted hemoglobin levels or hematocrit levels, And it has been shown that if you you follow the restricted policy, wherein you keep about 13 in the first week of life, and after 2 weeks one would give blood only if the hemoglobin falls below 7 or 7.5, then you are going to obviously reduce the number of transfusions, number one. And if you reduce the number of transfusions, you are going to thereby reduce transfusion associated morbidities such as transmission of CMV disease, graft versus host disease, and so many other transfusion related issues such as overload syndromes, it is trally, and so many other viruses which can get transmitted. Use of special equipment such as satellite packs or pedipacks and sterile connecting devices for small volume transfusion. One could use a single donor and restrict the number of donor exposures. Use leukocyte reduced and irradiated blood products in neonates, basically to avoid graft versus host reaction. Now, this is something of medico-legal importance that we need to take consent. Consent from parents or legal guardians is essential to reduce the number of is essential before you give any blood or blood products to newborns. Now, consent requires description of the blood product, whether you're giving PRBCs, plasma, or platelets. You need to explain them about the possible benefits and risks, and also mention the alternatives to transfusion. Now, this is something which I think we are writing on indoor papers of our babies. But once in a while, if there is transmission of some, say, virus like HIV, consenting is very essential to prevent us from medico-legal issues. How fast should the platelets be administered? Well, it should be given fast, over 30 to 60 minutes. Now, this is again a historical practice, but the platelets as a routine policy should be infused rapidly, and do not store platelets in room temperature for long period of time before transfusion. So one has to really give platelets quickly. As far as platelet transfusion and NICU is concerned, start immediately. Platelet concentration should not be concentrate should not be stored in the refrigerator of the ward. A separate IV line is essential whether you give PRBCs or platelets. Platelets should be given over 1 hour. Pre-transfusion drugs are not indicated, and there is no evidence that increase in platelet is greater if you give more than 20 ml versus 10 ml per kilo as far as newborns are concerned. So to summarize, one would give platelets if the platelet count is less than 25,000 and not less than 50,000. That's what we studied. We understood from the Planet 2 trial. Platelet should be group specific. Single donor platelet is much better than multiple donors, but they're more expensive, and give it over 1 hour. There could be a rise in the platelet, which is much more if you use a single donor platelet transfusion. With this, I would like to thank you for your patient hearing, and I'm happy to take some questions.
Sir, thank you for taking us through the journey of non-restricted to restricted transfusion practices. And also, all the messages were very crisp. And Shakespeare once said, brevity is the soul of wit. And your presentation was an example of that, sir. So thank you once again. There are few questions. So Dr. Narasimha Rao wants to know more regarding reperfusion injury leading to NEC in preterm.
Now, again, it's a very excellent question as far as NEC and transfusion is concerned. If you look at preterms, and NEC typically occurs in the second or third week of life, and not in the first week of life. So there are multiple factors which are associated with development of NEC. But moreover, initially it was understood that probably we give blood and it was NEC. So this was a transfusion associated necrotizing enterocolitis, and the whole mechanism was whether it was T activation or whether it was inflammatory cascade which got activated. However, restricted group, if you keep low hemoglobin, they may be more vulnerable for anoxia, hypoxia, and there could be an increased risk of NEC. So as of today, we really don't understand the pathophysiology of transfusion associated NEC. But what we really understand is that avoid too little or too much. And I think we understand that one should maintain a normal hematocrit and follow the guidelines. And there is no increased risk of NEC if you follow these policies.
Dr. R.H. Rohit, you can unmute yourself and ask your question.
Yes. Sir, can I ask?
Yes, yes,
Yeah,
please.
sure.
Sir, which type of transfusion set you use for platelet transfusion, sir?
Pardon, sir.
Platelet transfusion, which
Huh.
size set you use? Sometimes they are saying not to use regular blood transfusion set because the filter will cause occlusion. So they are using a sterile IV set. That
I think we could use a sterile IV set to give platelets so that the platelets are not inactivated.
not routine blood transfusion set.
Not routine blood transfusion.
Thank you, sir.
So Rohit's question is GRBS monitoring using RBC transfusion.
Should we really be doing a blood glucose? The answer is, if we do a blood glucose before giving transfusion, if it is normal, we need not do a sugar unless you are giving it over a prolonged period of time. Number one, but most important, if you give blood, there is a risk of developing hypoglycemia after transfusion. So one should do a sugar after transfusion and not during. Even while doing exchange, people do a sugar, but most important, post exchange there is a risk of hypoglycemia, and this is related to the CPD concentrates. That dextrose in the blood is going to give you hyperglycemia, and there could be a rebound hypoglycemia after that.
Leon wants to know the reason why irradiated PRBC should be transfused within 24 hours of irradiation when shelf life is 28 days.
The studies that have shown that if you give after 24 hours, the platelet life is reduced as compared when you have irradiated. The shelf life is 24 hours.
Amit, you can unmute and ask your question, please.
Sir, I would like to know one thing. You said that in third and fourth week, if the baby is anemic and has got pre-threshold ROP, transfusing would rather arrest ROP in this situation. So what is the mechanism behind? Because we are, after all, increasing the delivery of oxygen by transfusing the adult PRBCs.
In the third and fourth week of life, what has happened is you have got neovascularization, correct?
Yes.
And if the baby is anemic, there is a higher chance that erythropoietin is going to get upregulated. So it not only causes increase in RBC production, but it also causes neovascularization. So if you maintain a hemoglobin of 12, you are going to increase the oxygen delivery at the retina, which will down-regulate the retinal blood vessel growth.
Okay. But that doesn't hold true for the first week.
First week, no. First week, no. There are two phases of ROP. One is the vasoobliteration, and then there's vasoproliferation. In the first week, if you have to, if you give high oxygen, you are going to cause problems. In the third and fourth week, you could maintain slightly higher hemoglobin. And that was the same basis of the STOP ROP trial, which was done ages ago in, I think somewhere around 1990s or early 2000. And maintaining higher saturation decreased the incidence of threshold ROP, but there was the increase in the incidence of BPD.
Right, sir. So second thing is regarding the platelet transfusion, they get clumped. So is there any agitation that is required while transfusing them when we are transfusing for 1 hour?
If you give it over 1 hour, I don't think agitation is required. But yes, you could manually do it while you are while there is somebody is there. But otherwise, no, not as a routine.
Thank you, sir.
Jyoti wants to know, old stored PRBC will have less amount of 2,3 DPG than fresh. So why to prefer old versus?
So it is just to have a constant supply of blood in the NICU, in the blood from the blood bank for the NICU. It doesn't mean that you have to give fresh RBCs all the time.
And her second question is how to calculate hematocrit of donor blood.
You could do a hematocrit from the sample, and it should be around 60 to 70 before you transfuse.
Right. Dr. H.R. Rohit, you can unmute yourself and ask your question.
Yes, sir. Regarding the packed RBC transfusion, sir, we are not getting the smaller volume bags. We are getting only the like 100 ml, like 300 ml, 150 ml, like that bags only.
I think what we had a similar problem, but we need to speak with our blood bank, and you have to convince them to get small bags, and it could be a cost-effective affair. Not only does it reduce the cost, but also it reduces the donor exposure. All that they
Yeah.
need to do is transfer blood from a big bag to a small bag.
And one more thing, sir. Suppose in the blood transfusion, if they want to give, suppose the baby is 1 kg only, we are giving 10 ml or 15 ml, and they want to take that 15 ml in syringe and they will be transfusing with the syringe infusion pump. What is directly transfusing from the blood is good, or transfusing from the taking from syringe and once again transfusing to the infusion pump? You got my question, sir, regarding
No,
the.
I did not get your question.
Actually, some people what they will do, they
He
will
wants
extract the
to
blood
he wants to ask whether the transfusion directly from the bag is beneficial compared to taking the desired amount in a syringe pump and then transfusing, sir.
I think you could take it in a syringe pump and transfer. There is no harm. In fact, you are going to be more specific in terms of your volume, especially in small babies.
What about other remaining volumes, sir? We can keep in the refrigerator and
No, you have
reuse
to
it.
discard. You have to discard it. You can't use it again.
We can't use it again, sir.
No.
The syringe pump set won't be having filter, sir.
Filter will not be there, and
I think we need to have a leukocyte filter, or because it is very important to know how much volume we are giving the baby.
okay. Usually we will be transfusing from 1.5 kg or 1.2 kgs. We'll be giving hardly 15 ml or 20 ml, sir. That's why what they will do, they will take in the 20 ml syringe or 50
syringe
ml
pump,
syringe.
In
Yeah,
smaller
then
babies, in
yeah.
small babies, often they do give transfusion through a syringe pump.
That time there's no filter, nothing will be
filter,
there,
yeah.
and also they won't maintain the aseptic precaution. Nothing will not be maintained, and
No,
that's why any risk
aseptic precautions have to be maintained. I mean, you just have to withdraw it, and with no touch technique, you have to transfuse. You can't have. You can't possibly follow that. Yeah.
Plus, if your blood bank is giving leukodepleted, then you don't need filter also.
Yeah. Then you don't need a filter anyway.
It's very difficult to get leukodepleted and irradiated, sir. Only we are getting fresh blood only. It's very difficult, sir. Okay, thank you, sir. Thank you for.
Rashmi R wants to know HB cutoff for partial exchange transfusion, and other question is formula used to calculate the volume.
I think symptomatic polycythemia people have looked at 65 and asymptomatic 70 as a cutoff, and formula I think we'll have to if you go through any it's desired what is the current hematocrit minus what is the target that you want to check divided by current multiplied by weight is what I think they look at the formula, but I'll have to cross check that formula. It is usually about 15 to 20 ml per kilo.
Dr. Jyoti wants to know how to treat trally, and related to this, sir, how common is trally in newborn? In your practice, how commonly do you see trally?
Trally is not very common, but again, it is a diagnosis which making a diagnosis of trally is itself very tricky. We often attribute that to sepsis rather than trally, but once in a while we do see a baby who is otherwise stable, and after blood transfusion, the baby goes on to CPAP or baby's oxygen requirements go up. And we need to have a high index of suspicion of trally, number one. Number two, in that case, give oxygen, start CPAP. There may be a role of giving small dose of steroid just as an anti-inflammatory effect, but otherwise it is just supportive care that would work in a baby with trally.
Bhattirath wants to know when earliest to check HB levels post-transfusion.
One would have to wait at least for about 12 to 24 hours before checking the next hemoglobin levels. And if you have a baby with severe anemia, maybe a slightly earlier.
What about giving Lasix, sir? How much mg we have to give?
1 milligram per kilo. Give it only if it is indicated, where the baby is more likely to go into congestive cardiac failure, or a baby who is very small, has a large PDA with anemia. One may think of giving a diuretic, but otherwise routinely don't give diuretics as a routine protocol after transfusion or before transfusion.
Not in the early, mid, or late.
No.
Nothing.
It
Only
hasn't
after the transfusion.
It hasn't shown to be beneficial as far as diuretics are concerned.
If I want to give it, sir, what time I can give?
You can give it after transfusion, but not as a routine. Avoid as much as possible because Lasix has its own side effects.
Okay, how much is the transfusion rate I can keep, sir? Because if I can give in the UVC or
you can give it to UVC. You can give it over 3 to 4 hours.
Okay, sir. 3 to 4 hours. Like if it is 120 ml means 20 ml per hour or 30 ml per hour, I can give it, no?
Depending on
4
what is the weight of the baby.
4 kg
15,
baby.
15 ml per kilo. So you are giving 4 kilo, 60 ml.
60 ml. Okay. 15 ml per hour, I can give.
Veer wants to know when to check platelet levels post-transfusion, and satellite bags are stored in blood bank or we can store in fridge.
You could check a platelet count again after 12 to 24 hours. There is a rise in the platelet that about 10 to 15,000 if with a random donor, and if it is a single donor, then platelet counts may go up by about 40 to 50,000. Those were the adult studies. Satellite bags are stored in blood bank and not in our refrigerator or not in our NICU fridge.
Dr. Jyoti has a question: how to take care of CMV transfusion and how to treat it?
Well, there are 2 or 3 ways by which one could look at CMV. Use a CMV negative donor. One could use leukodepleted RBCs, and irradiation may or may not help CMV, but basically leukodepletion and CMV negative donor.
And Dr. Amit wants to know, when do we suspect tragi and manage the same? Again,
feeding intolerance, abdominal distension, sudden appearance of yellowish aspirates, and features which again suggest that the baby who was otherwise tolerating milk has now shown features of NEC like picture or feeding intolerance, suspect tragi. And herein, you would keep a baby nil by mouth, wait for the baby to see the progress, look for other parameters in the form of potassium, sepsis workup. When everything is negative and still baby has features of abdominal distension and gastric residues, think of tragi. The treatment here would be just to wait, keep nil by mouth, start IV fluids. Usually it is self-limiting and it would settle down.
Do we have time for a few more questions?
Maybe sir, we can take 2 more questions and then end. Sir has been traveling all the day.
No, I'm happy, no problems.
So regarding PRBC transfusion in babies having NEC, should we be following the same cutoff limits, or we should tailor it for babies having NEC?
Now, this is a very excellent question, because obviously NEC, blood transfusion, its effect on the gut blood supply, its effect on T cell activation, they are very intricate and complex. So as far as NEC is concerned, I think we would be a little more conservative about blood transfusion, number 1. Number 2, give it unless indicated, don't give blood transfusion. Number 3, one has to be very careful about RBC transfusion in these babies, because if I look at giving blood, it may have its own hazards in the form of worsening of the neck. So keep it ready, maintain a low threshold for lower threshold. Suppose in the first week of life, if you have maintained about 12, one could wait till about 10 and give it unless it falls below 10. So be a little bit more conservative about transfusion in NEC, because there is a risk of worsening gut injury in these group of babies with blood transfusion.
Regarding feeding and PRBC transfusion, you have already.
I think we could feed the babies even while we are giving blood transfusion. That's
true, sir. Regarding Iowa trials, what may have been the reason for more IVH in restricted transfusion group?
What was really fascinating to think about was whether it was, if you look at the cutoff threshold, it was 15.3 in the high threshold in the first week of life, number 1, versus the lower cutoff was 11.2 or 11.3. Now, this is something which people felt that if lower threshold, there was more hemodynamic flow, which could have resulted in IVH. That was their hypothesis. However, it was not proven in the subsequent bigger trials. And Iowa trial had only 100 babies with 51 and 49 in the higher versus lower threshold group.
Regarding consent, sir, suppose we take a consent and the baby needs repeated transfusion. So how long does one consent is valid?
I think it is always a good idea to take a repeat consent when you are giving a next blood transfusion, because it is obviously we have a habit of taking a blanket consent for all babies who are admitted in NICU where any sick newborn is concerned. But as far as blood and blood products are concerned, it is a good practice to take consent before giving a next transfusion.
Sir,
Hindu-
in a
Yes,
polycythemic, sorry.
Yes, madam.
Sir, so in your experience in a polycythemic baby, is it like the policy of seeing PCV for giving cystolytes bolus? Is there no incidence of hemodynamic instability as far as having a higher HB and giving boluses as well? So what does exactly your experience say?
When you look at a baby who is polycythemic and the hematocrit is really high, and by that we mean that more than 65% hematocrit is polycythemia, instead of giving a bolus, give more liberal fluids. And liberal fluid versus restricted, I think giving a 20 ml per kilo extra fluid over 24 hours probably would be the way, rather than giving a bolus. Because obviously if you give bolus, you're going to cause hemodynamic instability, and that may sometimes be detrimental as far as IVH is concerned, number one. And number two, do a partial exchange only in symptomatic babies where you think that partial exchange is indicated. Now, if you look at evidence, it isn't in favor of partial exchange, because partial exchange versus no exchange, the long-term outcomes are no different.
Right.
Those are old studies. Luckily, in the today's time and era, we are not seeing those many high polycythemias, because probably our IUGR population is going down because of better antenatal care. But with the setting of delayed cord clamping, there is always a risk of polycythemia, which may come up in days to come. So one has to be very judicious.
Right.
Especially in preterm babies, I think give more fluid over 24 hours rather than doing a bolus, because boluses are indicated very rarely in NICUs, because only place would be a shock where you would give a bolus. Otherwise, madam, I would not recommend bolus for polycythemia.
But
Right,
is
sir.
it
Thank you, sir.
helpful to remove small quantity of blood in high PCV and then gives saline for 24 hours?
I think,
Excuse me, excuse me, sir. Can you tell me the dose of the platelets in the platelet transfusion?
it is again 10 to 15 ml per kilo.
Okay.
Sir, PCV, please tell, sir.
I think you are doing a little bit of blood let down. We all have got those habits of taking out some 510 ml and giving 510 ml of normal saline. Now these are uncontrolled, unscientific, rational, out of personal experiences, which probably have no standing in evidence-based practice. So if you are doing partial exchange, might as well do it properly.
Thank you, sir.
Sir, want to know one thing, sir. Is
Yes.
there any study which is showing that at what hemoglobin level in a premature baby the EPO surges, sir? Erythropoietin surge is seen?
In a preterm baby, erythropoietin surges basically is a very interesting phenomenon. If you look at second trimester, the erythropoietin is produced in the liver, and in third trimester, it is produced from the kidneys. The switch from liver to kidney may take some time, and the receptors may act differently at different level of hemoglobin levels. So there is no correlation or association that if the hemoglobin falls below 10 or below 9 or below 8, the EPO production starts. Sometimes the kidneys may not really, the switch from liver to kidney may take some time, and it is different in different babies, and it may act differently at different level of hematocrits. So there is no direct correlation.
Okay, sir. Thank you, sir.
Is there anyone wants to ask any question?
Dr. Rashmi, last question.
Yes,
Doctor-
madam.
Dr. Rashmi, are you there?
Audible?
Huh.
So
Yeah,
when
you're
do you
audible.
expect partial extent transfusion in case of severe anemia over simple PRBC transfusion? What's the
No.
cutoff you take?
No, I did not get your question. When do you want to do a partial exchange? Why do you want to do
Yeah, if
partial
the
exchange?
hemoglobin is very less, or if the baby has high drops, or in
So if you have this was a classical setting in case of a RH isoimmunization. if you have a baby with hemoglobin of 3, the question here is whether you want to do exchange and then give blood versus giving a blood directly. Is that right?
Yes, sir. What is the HB cutoff you take?
You don't do a partial exchange. You could probably give some packed RBCs immediately after birth to optimize the hemoglobin levels, and maybe do an exchange later on, because the baby may not withstand the exchange transfusion as far as RH isoimmunization is concerned. But by and large, if the baby has got severe anemia with hydrops, you may have to do an exchange as earlier than later, depending on the rate of rise of bilirubin and optimization of the hemoglobin level, after optimization of hemoglobin level. So maybe I would give some blood, and then once we have optimized and made the baby a little bit more stable, one could do exchange.
Yes, we come to the end of this session. On behalf of Lucknow Neonatology Foundation and NARC, I thank you very much, sir, for elaborate and very interesting question answer session also. And I thank all the attendees also. And over to you, Dr. Akash.
Thank you so much, Niranjan sir, and thank you, Sandeep sir, for making it despite a busy schedule and a busy travel. We enjoyed the journey drop by drop. Each slide was a masterpiece. Lots of learning, and we hope we inculcate these points in our day-to-day practice to improve our newborn care. Thank you again, and and good night, sir. And thank you so much for taking time and making us all aware of these small tidbits.
I take this opportunity to thank each and every one of you for your patient hearing. Thank you, Lucknow NNF.
Thank you so much, sir.
Thank you. Good night.
Good night, sir.
Good night. Good night.